So, welcome. Good morning, good evening, good afternoon, depending on where you're arriving from. I see that I have people from all of those spaces. I want to warmly welcome you all to our conversation today around coaching the person and not the diagnosis. I see we have a few more people coming in as we begin this process, and I want us just to gently hold the space for those who are moving into this environment with us and welcome them warmly. See some other familiar faces. Cavalin and Mike, so nice to see you. Welcome. Hello, Cavalin. Colette, nice to see you. Welcome. So my name, for those of you that don't know, my name's Brad Hardie, and I'm one of the principals with Moving the Human Spirit. And the other principal is here with us today, Susan Hogarth. She's my business partner in crime and wealth, thankfully, if we can get there. So we are busy working in this environment of trauma-informed, and today's conversation is going to be on actually trauma-informed coaching, but how we can work within this lens of post-traumatic stress disorder. So many of you know that June is National Post-Traumatic Stress Disorder Awareness Month. The intent behind this, of course, is to raise public awareness about issues related to post-traumatic stress disorder. And we do that, anyone that's working in this environment, of course, we do that in hopes that we bring more awareness about the issues related to post-traumatic stress disorder. We also hope to reduce some of the stigma that also goes with that diagnosis, and to help those with what they call the invisible wound receive some of the resources and help on their healing journey. So glad that you guys decided to participate in this. It's certainly meaningful for many people, certainly some of the collective that we work with that has gone through trauma and as a result can get this particular diagnosis. So thank you for that. So as trauma-informed coaches, we're non-clinical. We do not diagnose or we do not treat our client. That's one thing I like to tell everyone from the very beginning. So the work that we do does not require the client's disorder to take center stage in order to accomplish a positive shift. And what I mean by that is that we start working in a place where we look at the person and not the label. And that's where we prefer to do our work. Our work evolves solely around the individual and the mind-body connection that they have, some of which we want to discuss here today. So by holding our clients as completely capable and competent, that they're not broken and don't need fixing, they're whole and resourceful, we explore with them through questions, and questions help build that understanding, self-awareness, and making meaning of what they may be experiencing. So all of our work is really based in getting really curious about what might be coming up for people, the mind-body connection. We'll talk a little bit more about that as we get into today's talk, and really being able to help them become efficient and sustainable within whatever presents itself through some of this disorder. So we want to thank you all for joining us today and to generate this conversation around the field of coaching and how we can contribute to the process of clients healing by focusing on the person and not the disorder itself. So I'm just going to go over the definition for those of you who may not know what post-traumatic stress disorder is, referred to as PTSD. So it's a psychiatric disorder that is in the DSM-5, and it may occur in people who have experienced or been witness to a traumatic event. So the interesting thing about it is that I said it may exist in people that have witnessed or had a traumatic event. Not everyone actually develops post-traumatic stress disorder from having gone through a trauma or being in or witnessing a traumatic event. So, but these events that can happen that do create post-traumatic stress disorder are things such as natural disasters. We think about accidents. We look at things such as genocides, racism, suppression, acts of terrorism. We think of cultural unrest or cultural dis-ease, if you will, war-torn environments. Think about some of the things that people see in war-torn environments, what has happened to them. Think about sexual assaults, life-threatening encounters, or also serious injury. Those are some of the areas that a person can be exposed to, and as a result of it, can then develop post-traumatic stress disorder. So PTSD can occur in all people. So anyone of any ethnicity, any nationality, any culture, at any age. So it goes to one of the things that we talk about a lot in our work, that trauma and its effects do not discriminate, no matter what's happening. Post-traumatic stress really manifests itself in this intense, disturbing thoughts, feelings, sometimes relating to the experience that one has encountered. Now, the interesting thing about it is that these disturbing thoughts and feelings can then carry on long after the event itself. So some people who experience this disorder can find themselves caught in what we refer to as a loop of reliving the event itself through things such as flashbacks, night terrors, nightmares. So it would feel as if they're constantly reliving the event within this loop, which, as you can appreciate, can be quite tiresome and daunting for people. The intensity of actually reliving the experience can create feelings of extreme emotions. Those can show up as sadness. It can show up as things such as fear and anger. We see detachment. What I mean by that is people stepping away from their regular life. Dissociation, not only from the environment that they may be in, but also sometimes from the people that are in the environments they're with. Sometimes even the people that they start detaching from or dissociating from, if there was people that had actually witnessed or gone through the particular traumatic imprint with them, so that people will then start stepping away from what their regular life used to look like. So this is that area where we start to think about maladaptive behavior. So today I wanted to just touch on maladaptive behavior and the adverse reactions that present themselves for people. So it can be presenting itself around something that was once considered non-threatening. So for an example, someone may experience these particular flashbacks or intense memories around something that at one time didn't present a danger to them. We see it often in things such as being in a crowded place. If something traumatic happened in a crowded place, people start to have a sensitivity to that. We think about it in some instances, hearing a loud noise. Oftentimes people would refer to it, if you think about in early days of diagnosing post-traumatic stress disorder, when it was considered things such as shell shock. In the early days, we used to think it was a disorder that would come from being in active war, World War II, World War I. We saw a lot of that. So it was about actually attaching these emotional pieces to things that used to be unthreatening. Think about even a sense of smell. Sometimes that can activate these intense feelings. So the thing to remember is that PTSD doesn't have to come from just war-torn countries. It comes from almost anywhere in our lives. It could occur in an individual learning about a violent death of a family member or a close friend. It can also occur because of repeated exposure to horrible details of something. So I think about some of the occupations where people are exposed to some very extreme conditions. Think about working in, again, police working in things such as child abuse cases. We think about people who are environments, think along the lines of first responders who are responding to incidents, usually of an extreme disorder, of an extreme condition. So having to constantly come back to that place, being exposed to it over and over again, can then impact some of the post-traumatic stress that people have. The other interesting thing around post-traumatic stress disorder is that there are usually two different kinds. There's one called complex post-traumatic stress disorder. There's one called post-traumatic stress disorder. And the differences between post-traumatic stress disorder and complex PTSD are that usually the complex PTSD, there has been a beginning within a trauma space that happened in childhood. So some of the people that develop a complex post-traumatic stress disorder, it's usually because early on in their life, if you are familiar with an ACE score, which is calculating the adverse childhood experience of people, anyone that seems to have actually had an adverse childhood experience or a traumatic child experience or background tend to move into at later ages in their life. They tend to be the people that actually experience complex post-traumatic stress disorder. And again, that comes up a little bit from the conversation around maladaptive behavior for us. Because of the time of being a child, what happened was they had coping skills at a certain age, usually quite young, that as they aged, they had forgotten about because they became an adult. And then at those older ages, when a trauma is represented, those maladaptive behaviors present themselves again. And they, of course, in being a child, would have been attached to some very early emotions and very early coping mechanisms. So not fully developed when it comes, thank you, Nadine, not fully developed emotionally. As you know, as we're ranking now, I think it takes up until anywhere from 25 to 27 now, when we are considering that adults are emotionally intelligent or have developed fully emotionally. Any questions so far before I go on? I should check in and see if anyone has any comments or questions. Any asks? No? Are we good? Is this making sense to everyone so far? You can all hear me?
So, Brad, are you saying that the coping skills for someone with complex PTSD, that their coping skills morph into maladaptive behaviors?
Well, I'm not saying necessarily, well, not necessarily saying they morph into maladaptive behaviors. Generally what we're seeing, what, sorry? Oh, sorry.
Go ahead.
Yeah, sorry. What we're seeing, Mike, is that maladaptive behaviors present themselves as a result of the post-traumatic stress disorder. That is across the board the same for both parties. And what I mean by both parties is that is the same across the board for the complex or the regular post-traumatic stress disorder. But with the complex post-traumatic stress disorder, the behavior system is not only from the immediate response, but some of the old coping mechanisms. So say, for instance, a child in a place where they may have had to go through the process of fawning or submitting to a caregiver or parent that was not necessarily doing the job of a caregiver or parent. So the child develops coping mechanisms for survival or safety at that time because they're not old enough to leave the place. They're not old enough to mind for themselves. So there is a tendency to create coping mechanisms for them to survive that environment. And then if they do come face to face with a traumatic imprint later on in life, they're finding that some of those old coping mechanisms come up. And as a result of it, it makes the particular immediate post-traumatic stress reaction a little bit more complex, because then In a clinical, which we're not, but in the clinical setting, they talk about then having to work with older maladaptive coping mechanisms that are representing themselves, if you will. Does that kind of make sense, Mike? Answer your question?
So it's just when, as they were going through this trauma early on, they develop coping mechanisms, and as they grow into adulthood, whenever they encounter something that evokes that trauma, once again, they're dealing with the coping strategies that they had initially developed rather than coping strategies in the present moment.
They're
Is
dealing
that
with
what I'm hearing?
both of them.
Both of them. Okay.
Yeah, so that's what makes it complex, because we have some maladaptive behaviors that have come from the childhood experience, where they were not emotionally formed, if you will. So they had not developed fully emotionally. So those behaviors and how they react to their environments are going to be completely different to the adult, if you will. So what you see happening is that they're going to be presented not only with how they're trying to cope in the moment with the new trauma, but they will bring some of these older coping mechanisms forward. And as you can appreciate, our coping mechanisms when we're, of a younger age, within anywhere from 2 to 12, are much more emotionally different than our coping mechanisms when we are, say, 30 to 60, if you will. So it's a level of development. Is that clear as mud, Mike?
No, I think so. So the earlier coping mechanisms are just really based on emotion, because they don't have a reasoning capacity to work through them as they would once they hit adulthood. Is that what I'm hearing?
Yeah, they might be quite, to some people, they might feel like it might feel quite illogical on some responses. Of course, given the fact that the body does interesting things with us anyway, and we'll get into that a little bit too. Yeah, so it's really we see a bit of it with the pandemic in the last 2 years. We've actually witnessed a lot of people that have been, they've been, what's the right word? We've been kind of forced to stay inside, and the general communication and relationship or interpersonal interactions that we usually have been suppressed. And as a part of that suppression, people who have come through the pandemic or in the pandemic, we're seeing some really explosive reactions emotionally because of some of those old reminders, the old, being evoked the same way they may have been younger. I mean, and generally, it's anytime that society is being suppressed, there's going to be reactive emotion that happens because it can be quite damaging, because we're, as a people, we're quite social, and that's how we live our lives, but also how we heal. So it's kind of part and parcel. It all has like a connecting point, if you will. So yes, we see those old behaviors showing up. And some people in adulthood don't know where they're coming from. They don't know why they've been evoked. So, Kate.
Yeah, hi, Brad. Hi, everyone.
Hi, Kate.
Hello. Mike, I just wanted to interject, well, just not to Mike, but everyone. Sometimes you can have an experience in adulthood, Mike, where you develop CPTSD because it's about repetition. So if you've experienced trauma and it lasts over a period of time, then that can develop into CPTSD, where you kind of withhold and you withdraw whatever you decide to do with that as an individual. And that's another dynamic where it's not just CPTSD is often referred to where people have had childhood trauma, but you can have adult trauma where it just means it's been repetitive over a long period of time. And the way that you process it is the same thing as childhood trauma. It just means that you're processing it, it becomes more complex because it's been repetitive, or it's been over a number of time, like, if you've been raped or you're a refugee or something dreadful has happened, and you do all the things which the child did, but you're doing them in adult form as well, where you kind of battle down, you do everything that you need to do to survive and to create safety. So I just wanted to put that in that you can have that. Often it refers to childhood trauma, but it's, you know, it's very prevalent in adult trauma as well. So, so I just wanted to throw that in, if that makes any sense.
Yeah, thank you, Kate, for that clarity, because one of the things that I didn't mention is what Kate just said. When we think about complex trauma, we think about it being an extension, i.e., you think about a young child growing up in a country that has had civil unrest and growing into adulthood, not only the particular traumas that may have happened, you know, through the years, as Kate said, it's a compiling of trauma after incident. And then, of course, in adulthood, that continuing, which makes it, again, yeah, such a really important distinguishing factor between the complex and the, it's not regular, but just the post-traumatic stress diagnosis. So thanks, Kate, for that. Completely eluded out of my head to say that. Kristen.
Yes, hi.
Hello.
Greetings from Norway.
Welcome from Norway. Nice to have you.
Thank you. I just have a very simple question, because is it possible to have post-traumatic stress disorder if you have been just neglected as a child, neglected in like love and care, not necessarily having been hit by your parents or witnessed something bad, but just being neglected?
I'm non-clinical, so I'm unable to speak from the clinical point of view. But what we have seen in post-traumatic stress from a coaching point of view is that it can present itself. The markers for post-traumatic stress don't necessarily come from one single thing. The diagnosis in the DSM-5, Nadine's smiling because I usually get that wrong. I usually do DSM. So what usually happens is it is a principle or a list of markers. So for me, to answer your question from a coaching point of view and a non-clinical or diagnostic point of view, where someone came and presented something that they were diagnosed with post-traumatic stress disorder, for instance, if this will make sense, Kristen, I'll use an example. I've had people that have come to me and said, oh, I've been diagnosed with post-traumatic stress disorder, but I have never seen any service. And to me, that it's not that you have to actually have been through, you know, what we initially think of post-traumatic stress. It's that whatever has been presented in your life overwhelmed the coping mechanisms you had at the time. And as a result of that, at some point, you have created symptoms that marries to the outline of post-traumatic stress disorder. So having said all of that, I don't think there's any one determining factor which says, oh, you can't have it unless you've gone through these steps. So I hope that helps answer your question.
Thank you.
Yeah, you're welcome. Janet's saying many mental health resources here in Canada show that neglect is a form of child abuse. Yeah, good point, Janet. If that helps you tie it in. Yeah, beautiful. So trauma-informed coaching as a practice is about understanding the presence of trauma while we work within a coaching client relationship. So we know that to be true. And not only being able to notice it, but to be able to work with the nuances in a productive way that without returning the client to the past. So one of the things that's very different about the work that we do in our practices is that we do not have to go to the past to retract or gather things. We don't need to help the client relive the past. We don't have to re-expose them to the past. So a lot of people always go, well, if you're not working in the past, how do you actually do this work? that it assists clients with post-traumatic stress? Well, by learning techniques that help guide the client through things such as the interpersonal aspects of their lives. And what I mean by that is their relationships. As coaches, we really just explore those relationships with themselves, with their environments, and their relationships with other people. So we look at them through all of these lenses. And one of the things that we're able to do as we do this investigation is that we're able to bring awareness to these places. We're able to look at these interpersonal relationships and look at how they show up in the environment, and to be able to look at what behaviors present themselves. And the reason we do that is because we want to work towards creating this healthier connection. Again, I'll mention that trauma doesn't heal itself on its own. So we find that the connection within communication and within relationships is really important. So what we want to do is be able to bring awareness to the clients so that they can then further these connections, which then help lessen the impact of the post-traumatic stress symptoms. So with this deeper awareness of their body and all its parts and how they relate to each other, the inner working of the mind and the sensory system, treating it as a whole. So what I'm saying here is we're taking all things into consideration: the sympathetic, the parasympathetic nervous system, which reacts throughout with our senses, emotions, and how one may interpret them. So interpretation of what's going on for us, what the body's objective is when presenting within its environment. So what kinds of stimuli are in the environments that people are in, and why overall the body is reacting in a certain way to a certain experience. So trauma-informed coaches, of course, have training in things such as client regulation, the brain-body connection, behavioral reaction. We really try to make it a top-down and a bottom-up approach. What I mean by that is that, we not only do we have conversations and dig deeply with the client, but we also think about and work somatically with them about what's coming up for them, what's being presented in their body. And of course, we do all of this without having to revisit the traumatic event itself. So the depth of information and knowledge and skill to hold that space for people is a profound coaching work that is encompassed within the trauma-informed lens. And it's what gives it its nuance and ability to do and create these changes. Colette, I'm going to answer Colette's question here. How would going back to one's past affect post-traumatic stress disorder? From a non-clinical point of view, Colette, what we do, the reason that we don't revisit the past is because we don't want the client to actually have to relive any experience that's not serving them a purpose. And what I mean by that is that in coaching, we work directly in the here and now, and we work towards the future. And the thing, if you will, is that we refer to the past and honor it where it is. So we don't look at the past as a piece that we have to dissect or dig into. And the reason that we don't do that is because there's one thing I know about the past is that I have no control. I can't change it. Every human can't change their past. We can reflect on it. We can honor it. But as coaches, what we do is we leave the past where it is. It may inform the here and now by who we have turned into as people, and that can be very positive. But working in the past, one of the other things that we caution is that it may bring up stuff that a client doesn't necessarily have to relive. I know in clinical work, sometimes the clinicians, depending on who they are, prefer to work in the past. There's different techniques such as exposure therapy, these different things. In our work, what we want to do is we want to firmly stay in the here and now and really promote that great conversation of moving people forward into a life that they want, as opposed to the life that they had. Because the life they had, we can't change now. So, oh, thank you, Colette. I hope that was helpful. So when we start thinking about some of these maladaptive behaviors that Mike and I were talking about a little bit earlier and how they present themselves, by definition, maladaptive behaviors, they're defined as those behaviors that actually just interfere with an individual's activities on a daily basis. So they're those things that present themselves that kind of make it more complicated for us to actually live. And they usually present themselves in particular situations. If we think about some of the more common maladaptive behaviors, we look at things, again, such as avoidance, emotional outbursts. We think of those as reactiveness, passive aggressiveness, dissociation or withdrawal. Sometimes we also note self-injury or harm, substance use. Those are types of things that we look at as maladaptive behaviors. So when working with maladaptive behaviors in the coaching lens, we seek the underlying cause within the body and get curious about how it's presenting itself through unwanted actions or reactions, so to speak. So we're really coming from this place that the body is simply doing exactly what it's been designed to do, which is sort for safety for the organism. Anytime the body is reacting through its sensory system, what it's doing is it's sorting for safety for the person that is going through the adaptive behavior itself. So really just an instinctive evolutionary response we find in all mammals. It's something that every mammal has, and we have it to a level because we are able to run scenarios and we are able to be in touch with our emotions on a very different level. It can be or present itself in quite extreme manners, if you will. So to know what maladaptive behaviors affect our clients, we delve fairly deep into what behavior is being exhibited or what inappropriate reaction is being noticed in response to any external or internal stimuli. So i.e., again, if there's a flashback or a reminder of a traumatic event. We look at what behaviors attached to it and what the client thinks the body's positive intention is to begin with. So these behaviors can inhibit the individual's ability to cope and adapt to difficult or new circumstances. And that's one of the reasons we want to look at them, because we want the client to be able to go forward in a self-sustaining manner so that they can cope and adapt to new environments as they move through it and not feel restricted, if you will. So these particular things, of course, greatly weigh on the client or the individual and often lead to different symptoms such as health issues, which is an unusual, social structure and emotional regulation issues. And what I mean by social structure, again, is the interpersonal interactions. It prevents that connection from happening with other individuals, which of course then, as we know, can also be deeply damaging for health and welfare. Yes, Nadine.
I just want to honor that Huda has a question in the chat. She's asking,
thank
can we
you.
identify maladaptive behaviors as addictive behaviors?
You can, yes. Some maladaptive behaviors are addictive behaviors. I think of a maladaptive behavior, any addictions I see as a maladaptive behavior. Addictions, from how I view them, and again, in a coaching realm, a non-clinical realm, is generally presented in a few different ways. One, we see risky behavior being presented, and that's someone that sometimes has felt so numb to life that they're trying to bring forward some excitement to remind themselves that they're still alive. We see lots of addictions. You see things such as drug, alcohol, sexual disorders, gambling, eating disorders. Any of those things are maladaptive behaviors to help us cope with the underlying symptom, or sorry, the underlying behavior. So yes. Does that make sense, Huda? Yeah, thank you.
And then Harriet is asking, could coaching not be as successful until a client has worked through their trauma with a therapist, etc.? Would it be better for coaching to take place during or after therapy as a standalone?
Yeah, thanks. That's a wonderful question. So how we gauge that particular question is based on the client themselves, because we hold them completely capable to make their own decisions and to row their own boat, if you will. What we do is we oftentimes, I know in our work at MTHS and our associates, we work with clients who have either come through therapy, who are still in therapy, and we always suggest them to let them know that they're working with a coach. It's been very complimentary over the years, actually. Therapists and psychotherapists and counselors have been very supportive of the work that we're doing. And there, of course, there's crossovers because they work in some of the areas that we do as well. If you think about stuff such as CBT or neurolinguistic programming, there are bits and pieces that are brought forward. So to answer the question, Harriet, we ask the client how ready they feel to be in this, the presence of coaching. And because we're holding them completely from a place of capability. And then for me, I just think that it's a beautiful relationship to make with other therapists. And can we do it before? As a coach, we are also guided by the ICF ethical guidelines, which means we also understand when we should then refer a client out. So if it's out of our wheelhouse, we don't take it on. We stay within our lane, but we also can work side by side with therapists, or we can certainly work before or after. So I hope that answered your question. Good. And Allison says she has been studying the correlation with trauma and neurodivergence development and addictive maladaptive behaviors. What are our thoughts on this with maladaptive behaviors? I don't have enough information to give a conversation on it, but if you want to give us a piece of information of what you've been seeing, Allison, is there something specific you've noticed that's sort of helping make that connection for you?
I've just been studying in the UK doing the ACEs, and ADHD, ADD was coming up, and the behavioural patterns, and sorry, that's the dog just moving. The correlations of behaviour and mental health awareness were all coming back to a similar pattern. And obviously there is still talk that ADHD and neuro differences are genetic, but actually what's been thought is that it can be brought on. They may be, you know, suppressed at birth or whatever, but then they can be brought on through a traumatic experience, which is very similar to the ADHD response in not being able to control behavior, will be, what's the word I'm looking for? You use the word and I can't recall it. Just not thinking and responding. I can't think now.
Yeah, that's no problem.
Reacting either with anger and have no sorry, it's late at night for me.
No problem. I appreciate you being here.
It's kind of like, so no control over your behavior, so you're just
yes, Kate, yes. So you're either really calm, really collected, or the response is very, you know, unpredictable. And yeah, Gabor Mate speaks about this, and that's why I went in and studied the neurodivergence as well. And it was just pulling the links together, the obsessive compulsive behavior, the ways that we respond, the survival patterns were very linked. If you have a client I had a client actually not so long ago, and then we discovered the behaviors were so similar: traumatized, illness, chronic fatigue syndrome, and then boom, I made a suggestion, not directly about something like ADHD. And then they came back to me and said, I've had a diagnosis. And as we know, a diagnosis doesn't mean anything, it's the symptoms, but it was just that connectivity of the way that the brain then changes from the trauma and brings out these behaviors similar to neurodivergence. So
yeah, beautiful. Yeah, nice, Allison. It's interesting, right? Because as you know, even in my work, and again, you'll hear me say non-clinical a lot because I always want to differentiate between the work that we do to clinical practitioners, which I have, you know, we have great respect for. But for me, everything that comes down this, it's always interesting for me because I think it always starts with the person and looking at the person as a whole. And in Western medicine, I think we sort of moved away from that a little bit more than we should have. We started treating the head completely separate from the body. And I think to your point, Allison, anytime we start seeing these behaviors presenting themselves, and of course the DSM is there so that we can get a diagnosis, and then treatment can be utilized so that we can then contain some of these reactions to work deeper. So that I appreciate. But to have an idea that these things live separately from not just the human experience, to me, is quite mind-boggling. I just think that anything that presents itself comes from an impact or an association or an emotion or a reminder throughout our entire life. And depending on our mechanisms to cope, if you think about the work, the body keeps a score, or when the body says no, everything's directly correlated to how we're experiencing our environments and how we were either able to cope or not cope in them. So it makes such sense to me. So yes, I'm pretty sure, or I would say I have a good inkling that I'm sure that anything that presents itself has these originalities or original, even things when we think about intergenerational trauma, if we think about cellular trauma, which gets transferred, there's so many things now pointing in science, not that science is an absolute, but it has made us question more as humans about what might be coming up and how we might deal with it, if you will. So it is through these very closer examinations that bringing awareness, and bringing awareness is always key to this, bringing awareness to these behaviors with the intent of making meaning out of them, i.e. asking, why is this happening? And better understanding the positive intention behind them, i.e. the safety. The body's trying to remain safe. So if we think about the exploration of body awareness techniques, this can greatly help. So through conversations and awareness of how conscious and connected our clients are to their own body, this is where we start bringing in this concept or idea. So we employ things such as the visual, auditory, kinesthetic approach, and we find that that works well. What are you seeing? What are you hearing? What are you feeling within your body? Point to where that is. What do you think the intention is that it has for you? So again, having an awareness of the body and its parts in relationship to, say, our limbic system, which is, our emotional center, and how it responds or reacts, can really help us recognize what intention the body itself has. And as a result of having awareness to it, then assists in minimizing the reaction associated with the deeper intention. Because if we're not paying attention to our body will make us pay attention to it. We see that all the time. We see that in cancers. We see that in physical ailments. We see it, carried by people. So if we're not paying close enough attention, the body either will morph itself into something or present itself in ways that we have to sit up and take notice. By understanding and differentiating the changes that exist in the body and aligning our thought patterns and our emotional connection, we can begin then to map out a method or create a plan. Some prefer to call it that, to calm the trauma center through this deeper awareness. So that is how we work with people that may have some of this symptoms, if you will, or maladaptive behavior, shifts in conscious awareness, equip the client with better reaction skills, and change the relationship with the sensation they're experiencing. Oh, I'm having this sensation. I'm not going to force it away. I'm going to get curious about it, and I'm going to wonder why it's here for me. So they can have less judgment, less anxiety through analyzing the situation, which of course in return does what they have come to us to do. They have now suddenly made themselves self-sustaining because it returns to assist with letting go of those reactions. So the strength of the reaction or the power of the reaction has now been minimized. So in doing this, the client moves to what is referred to as the prefrontal cortex, that logical thinking center, and becomes more possibility focused, finding practical, realistic solutions as they're moving through their days. They're easier to access. When they practice this awareness, they're taking further control of the situation. And of course, we understand that they're taking control of this in confidence. So it's not only the mental piece of it, they're taking control of the physical side of it too. They can then participate in their environments with less disruption, less pressure, less stress. They respond with consideration instead of reacting through habit. And that, of course, options equal control, control equals safety. So by combining the person as a whole, capable, and that they have everything they need, they can move more freely between body and mind connection, feeling more present, expressive, which of course helps with interrelation. So with awareness comes this self-regulation, emotional regulation, and of course, self-care, which is what we're hoping for all of our clients. Full integration, mind, body, and spirit. So we have a few more moments. Thank you for letting me chat on about this. I get pretty passionate about it. So I'm curious, we have 10 more minutes, I think. Yes, 10 more minutes. Is there any questions anyone would like to bring up in the group before we say adieu?
Brad.
Yeah, Susan.
I just had kind of a question comment. So I'm working with a gal right now that had a relationship with a narcissist. And it was pretty intense. And one thing she realized is she showed up not as the person that really her authentic self, but you can look at the fond response and everything, like how she had to appease this person with that. So she's come a long way in knowing what she knows about the relationship. Today we met and she said, you know, it's just really hard getting over him. And all the things that were bad, it's like he's the worst one, but yet he ingrained in her more than anything.
Mm-hmm.
So, you know, like looking at this, I'm thinking, okay, so as we, like Gabor says, we keep it in our what's his name? Within, we keep it in our nervous system. So I'm just kind of like, stuff's kind of racing through my mind as far as when you're in a situation like that and you can have some real highs and lows, and it really, I think, sparks like a lot of emotions, good, bad, or indifferent, as opposed to, I think sometimes people like the trauma and I mean like that way, but like they become alive with all of that and not knowing how nice like peace can be.
Okay.
So my question to you is this kind of something that could happen to, like, with those kind of relationships, that even though in your mind you know they're bad and stuff, but it still kind of is resonating within the body?
Well, sometimes in the work that we do, we see people who have had traumatic background. In this particular case, I don't know, and I don't diagnose that for her because I don't do the ACE. But it sounds to me like there's two avenues you could work with this particular client with. I, of course, would be super curious, what's the positive that she's getting out of this relationship? I'd also be super curious if sometimes what happens to the body when it is used to being in hypervigilance is that when we're in calm, our body doesn't feel like it's in the right place because we've lived in hypervigilance for so long. We're used to the stress hormones and chemicals flooding it. And that can feel just as unsure as if we are in the danger zone, if you will. So I'd be curious if you mentioned, the reason I say that is you mentioned something there about peace for her. So I'd be curious too about finding out what peace means and if it's something that she's seeking. I mean, obviously the first question is, what does she want? What does she want instead of what she has? And I'm not sure that she wants anything other than what she has. She might maybe just says socially, I see that this isn't this isn't a good relationship for me.
Right. Well, she's out of the relationship, but like she's like, I still like kind of jonesing for, like, I miss him kind of thing, you know? But what's
Right.
interesting is she's a behavioral therapist, so she's done the ACE training. And initially I had her do a values assessment. And she said to me today, she says, now I understand what you mean about values, because she was kind of doing more extrinsic stuff. And now she's kind of going deeper with it. And I told her, I said, the further along you go, and you're going to take the value assessment later on in life, and you're going to find it's even changed then as you start to grow and evolve.
Mhm.
So it was kind of cool that she could make all that connection and kind of see. And like, of course, I couldn't say anything to her. So I just went, well, these are her values now, you know, and that's
Right.
what she's kind of like having to make that shift of living like this and then actually kind of going against who she really is and being able to sit peacefully with who she really is.
Interesting.
Yeah.
How does her belief systems match up to her values?
They're off and they're kind of getting more in line.
Ah, beautiful. Well,
And-
there's a
yeah,
great
yeah.
exploration as her belief system.
Yeah, that's where we're at.
Beautiful. Interesting. Good, Susan. Thanks. Kate.
Juicy stuff.
Yeah, guys, I just wanted to say that with disassociation, and I don't want to get too in depth about it, but I would say that if any of your clients are experiencing a feeling of complete disconnect, which is often what happens with CPTSD or PTSD, is any of these questions as coaches sometimes are really bewildering, because the disconnect is so, the void is there that you don't actually know the answer to the question. And a lot of people that I've been working with are like, they actually don't always know the answer. So I just wanted to throw that in there to say, and I'm interested in your view, Brad, on this and anybody else. You know, often some people are so like just in such a fury and fog around anything that actually all just completely removed. They can't answer the questions that you would say as a coach, which are, how are you feeling? What does your body feel about, you know, the normal stuff that we ask is kind of your, you know, some cases will be where they won't be able to answer that question. And that's okay with those clients, just give them time. And I don't know, Brad, if you want to lean into that a little bit, like sometimes clients won't know when you say, how do you feel about, where's that sitting with you? They'll be like, I can't even answer that question. And that might be an extremity or an extreme client, but often people won't know. And that's cool too. That's totally fine. It's just to put that out there that disassociation causes sort of this slight paralysis, and they won't necessarily know the answers to your questions. And as a coach, you ask questions. I don't know, Brad, does that make any sense, what I'm just saying?
Well, what you're talking about actually is familiar to me through what is known as in time or through time with our clients. In time and through time refers to how clients store memories. And in dissociation, clients usually store their memories through time, which means they are in front of them or beside them, left or right or up or down. And in time can actually associate with the feelings. So Kate was just referring to in time, we say they're associated with how they feel. And through time, we say they're dissociated with how they feel. So in dissociated clients, they may not be able to feel because they've compartmentalized any of those emotions and collapsed them all into a certain category, as opposed to, you know, this is what it feels like. In that particular instance, you know, being able to present it the way that the client is reacting, less in the visual, auditory, kinesthetic, you know, step into it, feel it, hear it, but more in if it was playing out in front of you on a movie screen. If you can associate with it and you're dissociated from the feeling, run the scenarios in front of yourself as if you're watching it on a movie, or tell me someone else that you see doing something that you wish you did. So being able to work with the dissociation in a sense that says it's okay that it's out here. You don't need to associate into it, especially if they're in deep dissociation. And then to Kate's point, just asking those powerful questions in the right way that the client can reflect that it works with how their memory system is stored, either in time or through time. And I mean, that's a conversation really more than an answer for me. I just wanted to honor, Harriet, you asked, is this approach similar to somatic experiencing, focusing, or IFS, internal family systems? Do you want to speak to that for me? Are you still here? There you are, Harriet.
Hi, sorry, I'm just in the UK and I'm just buying my barbecue actually, so it will be a bit
Good
of a
stuff.
strange
Flip a
visual.
burger for me, will you?
So I'll just keep the camera off. But yeah, what I'm sensing from what you said is obviously quite a body-centered approach. Correct me if I'm wrong. And I'm doing somatic experiencing at the moment myself. I'm having sessions for PTSD.
Yep.
I'm also having exposure therapy at the same time. So it's quite an interesting process. And just some of the things that you were saying, you know, like sort of, you didn't use these words, but I was sensing like a felt sense, you know, where it's like in the body type of thing. Quite often when I even end up doing that myself is I can go into a part really quickly. And that's why I was just wondering, is the approach similar to this? Do you stop at a certain point where it goes more into like, you know, really going into somebody's past? Or I don't know, I guess just explain a bit more about the actual process. It'll probably help me a bit more if that's okay.
Yeah, totally. So what we're
Thanks.
talking, yeah, thanks, Harriet. What we're talking about is we're actually not diving into the past so much. Thank you, Nadine. We're not talking about diving into the past. What we're saying is to bring awareness to these things and to just recognize whether it is a hard or a soft emotion. So we're staying within a positive realm. If I have a client that I see they're suddenly going down a rabbit hole, so to speak, the ability to be able to stop that process, which is what we do as trauma-informed coaches. So we would reframe, redirect, or release whatever's going on for them, as opposed to going up. Let's go deeper into that negative, or that reminder that is disturbing to you. Let's just associate with the feeling that you have around it, not necessarily what made you have the feeling, but what the feeling itself is presenting. And then if they were moving towards something that was less desirable, then to have the ability to draw them back out into, I'm understanding what you're experiencing right now. What would you rather experience in this moment than what you're telling me? So again, redirecting that to getting them back in the prefrontal cortex, so that we don't want them to go too far into the trauma brain, into the amygdala hijacking, as it were, because that'll take off the prefrontal cortex. And then, of course, we're unable to actually work with the client once their prefrontal cortex has been dislodged through that trauma brain attack, if you will, through the amygdala. I hope that's helpful. So it's not so much, we don't go deeply into them having to relive the experience. We keep on the curious line of understanding what's coming up by bringing language to the emotions. What do these emotions represent? What might they mean? Are they pleasant emotions or negative emotions? And then we work within that to draw out more of the positive, but understand why they're presenting themselves. I would almost think of it as a core alignment, so to speak, where it's like the really deepest understanding beneath of it is usually that the body is just trying to protect you from a negative impact of something in your life. I hope that made sense for you. And I'll take ketchup and mustard on my hamburger. Thank you guys so much for being here today. I see we've run out of time. It is such a pleasure to see you all. We are always online. We're open to anyone that wants to reach out with more conversation or further discussing this information. But thank you for showing up and being here today. Please, everyone, take care of yourself, and we will see you soon, hopefully. Nice to see you, Calvin. Calvin, nice to see you.
You too.
Take care.
Bye-bye.
Allison, nice to see you too. Take care. Yes, Stacy, I'll see you later on today, this evening. Mm.